Dear doctors, so we're going to continue with our MRCP PACES 23 consultation station, and today I'm going to talk a bit about the cystic fibrosis. Now this case can appear in your respiratory station as well, and you know there will be new consultation station, so there is a high chance that it can appear in your consultation station as well. So we'll try to cover both stations. Okay, let's move on and with our presentation. So first of all, as you know that new consultation station is going to be introduced by end of this year, and this is a 20-minute station actually, and you have first 15 minutes for your examination, taking the history, answer any queries from the patient, and the 5 minutes are for the examiners to ask any questions. Okay, so first of all, let's talk a bit about the history. This is a 30-year-old Caucasian female with a history of cystic fibrosis, and she presents with increasing cough and daily green sputum production for 3 weeks, associated with some dyspnea. She also reports a chronic blocked nose. She has been commenced on oral antibiotics, ciprofloxacin and trimethoprim sulfamethoxazole for 1 week without much improvement. Now, remember that cystic fibrosis is actually more common in people with a European background. So, approximately 1 in 25 people of European descent, they are carriers of CF mutations. Cystic fibrosis, it can affect both males and females equally. However, historically, women have tended to have poorer outcomes, lower life expectancy with cystic fibrosis. But there is no clear known reason for it. So, historically, patients with cystic fibrosis were diagnosed after presenting with symptoms, usually in childhood. However, now with the increasing growth of the newborn screening program, the majority of patients are now diagnosed as a newborn. The screening program currently involves testing for immunoreactive trypsinogen and cystic fibrosis transmembrane conductance regulator called CFTR gene mutation with the neonates. You've got 2 mutations being diagnosed with cystic fibrosis. However, the patient who have only 1 mutation, we need to do the sweat test to confirm the diagnosis. Patients with cystic fibrosis, they tend to have a persistent productive cough, which can worsen during periods of acute exacerbations. And you know that this is because of the CFTR mutation, which leads to reduction in ion transport, sodium and chloride of respiratory epithelial cells. Now, similar to mucus in the lungs, mucus in the paranasal sinuses is also thick and can block the sinus passages, and this can lead to recurrent sinus infection, and the chronic inflammation can lead to development of nasal polyps. So mild exacerbations are usually managed with oral antibiotics in the community without requiring hospital admission, and obviously the choice of antibiotics is often dependent on the previous sputum culture results. And patients with cystic fibrosis, they are at high risk for respiratory infection, and we have to be careful in maintaining some precautions to reduce the risk of acquiring infections. In particular, patients who have a history of infections with Burkholderia Chenocapacia complex, we need to be ensured that they are segregated from other CF patients. Okay, she denies any sick contacts. She also has a history of loose, smelly, fatty stools and is diabetic, requiring insulin. She has already been hospitalized twice in the past 12 months for IV antibiotics. Now, remember that pancreatic insufficiency, it is another common feature of cystic fibrosis. And normally the acinar cells in the pancreas, they release the digestive enzymes. And they release it into the pancreatic duct, where they mix with chlorides and bicarbonate ions that are secreted by epithelial cells, and then they travel into the intestine. Now, what happens with the CFTR mutation? There is decreased secretion of chloride ion into the pancreatic ducts, so which leads to reduced bicarbonate ion and water secretion in the pancreatic duct. So these thickened pancreatic enzymes, they do not travel as easily into the intestine, and as a result there will be mucus plugs in the pancreatic ducts, which actually worsen this process, and over time these trapped enzymes can digest the pancreatic tissue and it can lead to pancreatic insufficiency. Now, when there is a damage to the pancreas, it can lead to loss of the islets of Langerhans cells and leading to causing the diabetes mellitus. Patients who have cystic fibrosis, they may need to come into hospital regularly for tune-ups to manage exacerbation of their disease. The admission usually involves a course of IV antibiotics. So must inquire about the past history of IV antibiotics and hospitalization. She is a non-smoker. She currently works as an architect in an office where one of the colleagues also has cystic fibrosis. So remember that smoking is associated with worse outcome for patients with cystic fibrosis. And smoking results in cystic fibrosis patients, they have more frequent exacerbations which requiring the IV therapy and with worsening spirometry results. So additionally, I just like to mention, as I mentioned earlier, that depending on what pathogen the patient has on the sputum culture, it can have a large impact on their day-to-day life, as it may limit their ability to go to work. So must ask about the work history as well. So that's all about the history. Now let's talk a bit about the examination of this patient. So on general inspection, you notice this female with an approximately BMI of 19. She is alert and responding appropriately without displaying any signs of respiratory distress. She is breathing at a rate of 20 breaths per minute and saturating at 96% on air, has a pulse rate of 90 beats per minute and a blood pressure of 115/65 mmHg, and she is afebrile. So I mentioned all these things here. So respiratory rate you should count, and then you can mention to the examiner that I like to do the full set of observations, including the saturation, and obviously you want to check the blood pressure as well. So patients with cystic fibrosis, they tend to be underweight because of the pancreatic insufficiency and malabsorption. So this patient, normal oxygen saturation indicate that she is not in respiratory failure at this stage due to her respiratory distress. And SpO2, you can ask the patient, I want to know the saturation. Okay. So on examination of her hands, she has evidence of finger clubbing, and her heart sounds are dual without any added sound. Now, finger clubbing is actually enlargement of the nail bed and fingertips, and is associated with number of conditions, including the cystic fibrosis. The pathophysiology of the finger clubbing is not fully understood, maybe in relation to the secretion of growth factors from the lungs in some chronic lung conditions. So the other causes of finger clubbing include lung cancer, interstitial lung disease, tuberculosis, bronchiectasis, congenital cyanotic heart disease, endocarditis, and inflammatory bowel disease, which includes Crohn's disease, ulcerative colitis, or cirrhosis. So must remember, because sometimes the examiner may ask you about the other causes of clubbing. And remember that have to do the cardiovascular examination thoroughly, because patients with long-standing severe cystic fibrosis, they can develop signs and symptoms of pulmonary hypertension. So these includes a loud P2 heart sound with splitting of the second heart sound, and with progression of this disease, this patient can develop carpulmonale and is also known as pulmonary heart disease. Okay. So on auscultation of her chest, she has moderate expiratory V's and bilateral crackles. So on examination of her abdomen, there is no tenderness and no evidence of splenomegaly or hepatomegaly. So remember, cystic fibrosis patient, obviously it's a respiratory case, but if you are in the consultation station, you have to examine the respiratory system, you have to examine the hands, chest examination, as well as abdomen examination. So patient, they have usually have an element of airway obstruction, and then that can lead to a wheeze. And these patients can improve partially with bronchodilators. Coarse crackles, these are often a sign of bronchiectasis in patients with cystic fibrosis. And in bronchiectasis, they tend to clear with coughing. And it's a good idea when you are examining and you find some coarse crackles, ask the patient to cough, and then again auscultate on the same area, and maybe you note the crackles have disappeared, or there may be some change of the character of the crackles. So other differential clues, suppose if the patient has pulmonary edema, the crackles, they do not tend to clear with coughing. Now, patient with cystic fibrosis, they can have involvement of the liver as part of their disease process. So this results in thickened and slowing moving actually bile salts and release of pro-inflammatory factors that increase collagen synthesis within the portal tract. So eventually this lead to fibrosis and liver cirrhosis. Okay, let's talk a bit about the investigations in case of cystic fibrosis. So consider this patient. This patient has a routine ECG on admission, which is normal. Her full blood count reveals a mildly raised white cell count with a raised C-reactive protein. Her urea, electrolytes, and creatinine are normal, and she has mildly elevated liver enzymes. So I presented the case like this, but in the examination, if the examiner asks you about the investigation, you must know what investigations you like to do. So ECG in patients with cystic fibrosis, they are usually normal. However, with progression of the disease, patient can develop some right ventricular hypertrophy. So in an ECG, right ventricular hypertrophy all know is indicated by the right axis deviation, and there will be a large dominant R wave in V1 and dominant S wave in V5 or V6. A raised white cell count and raised CRP, well, it indicates that the patient is currently undergoing an inflammatory process, and this is most likely related to the chest. AST, ALT, and gamma GT can all be elevated in patients with cystic fibrosis, and this does not necessarily diagnose patients with cystic fibrosis related liver disease. However, if the patient do have any clinical signs of portal hypertension or have ultrasound findings or liver biopsy that show evidence of cirrhosis, then we can say that the patient may have a cystic fibrosis liver disease. Albumin, well, it's important to mention about this, is a useful marker of both nutrition and synthetic liver function in patients with cystic fibrosis, and more patient must have actually adequate protein intake and absorption to have normal levels of albumin. So her albumin is at the low range of normal. Her chest X-ray show evidence of hyperinflation and prominent bronchovascular markings. She has a spirometry test recently, which shows a reduced FEV1, 55% predicted, and reduced FEV1 FVC ratio. And she has a high resolution CT scan of the chest that revealed mucus plugging, periorbital thickening, air trapping, and airway dilation. She also has a sputum microscopy and culture sensitivity that shows Pseudomonas aeruginosa. Now, when you do the chest X-ray, hyperinflation of the lungs is indicated by a posterior rib count more than 10 ribs or an anterior rib count more than 7 ribs. It is one of the earliest changes in patients with cystic fibrosis. While with progression of the disease, this hyperinflation actually persists. It can be reversible initially, but as the disease progresses, it is persistent, and it can lead to the flattening of the diaphragm and prominent retrosternal space. So the increased bronchovascular markings, they are actually a result of a chronic inflammatory process affecting the airway in cystic fibrosis bronchiectasis. So as the pulmonary disease progresses, the dilated and thickened airway appear as parallel lines when these are known as tram tracks, and when seen longitudinally and as a ring shadow if seen cross sectionally. So patients with cystic fibrosis tend to have routine chest X-ray at a minimum of every 2 years, even with mild disease, to monitor for pulmonary progression of the disease. A bit about the pulmonary function test. Pulmonary function testing is a reliable way to monitor pulmonary progression of the disease in patients with cystic fibrosis, and such patients tend to have um, obstructive pattern, and in acute exacerbations, FEV1 may be reduced even further up by up to 10 to 15%, but it can improve with treatment. So the rate and pattern of decline of pulmonary function tests in patients with cystic fibrosis, they can vary greatly depending on their frequency exhibitions and the pathogens involved. So remember that mucus plugging can frequently occur in patients with cystic fibrosis due to thickened and excessive mucus production, and this can lead to obstructive respiratory signs, and it usually requires a strong course of chest physiotherapy to improve it. Airway dilatation is indicated by a very specific sign called signet ring sign, and you can see the airway dilatations here. Obviously the black thing which you see is actually the air there, and this actually relates to the appearance of a large dilated air-filled bronchus, and this is adjacent to a smaller opacity which is actually a pulmonary artery. And HRCT also can be used to measure the pulmonary artery diameter as a surrogate marker for pulmonary hypertension. So sputum microscopy and culture sensitivity is an essential investigation for patients with cystic fibrosis, as identification and sensitivities of the pathogen, they will help indicate the management plan. The common pathogen vary depending on the patient age, with Staphylococcus aureus and Haemophilus influenzae being the most common pathogen in childhood, and Pseudomonas aeruginosa being more prevalent as they get older. And other pathogens, I have talked about the Burkholderia capacia, and this is a very, very severe infection, very difficult to get rid of Burkholderia capacia. And in fact, it is one of the relative contraindications for the lung transplant. So Pseudomonas aeruginosa is most common. It's a gram-negative rod and frequently colonize the respiratory tract of patients with cystic fibrosis. And it is a significant concern because there is a high rate of antibiotic resistance and its capacity to develop biofilm, so it can survive for long periods of time. So that's all about the investigations. Now we come to the management part. So again, we divide the management to the immediate, our immediate management, short term and long term. So as the patient is a chronic cystic fibrosis patient who is currently hemodynamic stable, without any evidence of respiratory compromise, there is no immediate management step required in this situation. So short-term management, the management of an acute exacerbation of CF will commonly require an IV antibiotics for a duration of between 10 days and 3 weeks or more. While this commonly requires a hospital admission, some patients may be able to be managed at home. These patients will commonly require a peripherally inserted central catheter, which is called PICC line, to administer these antibiotics. The patient will receive twice daily chest physiotherapy, while in hospital, patient would also benefit from a dietitian review. So there are no set guidelines regarding the duration of antibiotics required during an exacerbation of CF. Generally, clinicians use their judgment, taking into account the patient improvement in symptoms and improvement in FEV1 to help guide duration. A course of at least 10 days is usually recommended, but can stretch to 3 weeks or more if there is slow ongoing improvement. While remember that hospital admission enables close monitoring of the patient and more intensive physiotherapy. Some patients, they may prefer a hospital at home program as they can be managed in the comfort of their own home. These PICC lines, these are long catheters and usually inserted in large peripheral veins in the arms, such as the basilic or brachial vein, and they are advanced towards the heart until the tip sits in the superior vena cava. They are commonly preferred in patients with cystic fibrosis, as such patient requires a longer course of antibiotics, and PICC line reduces the necessity of repeated cannulations. A bit about the chest physiotherapy, which is an essential component of the management of pulmonary disease in cystic fibrosis, and the aim should be to work on an effective cough which will clear the infected bronchial secretion, and it will help relieve airway obstruction. So there are different techniques available, and then the regimen should be tailored to suit the patient, because non-compliance with the chest physiotherapy is common. So, as a result of pancreatic insufficiency, patients with cystic fibrosis is generally recommended to have a high-calorie diet in addition to the pancreatic enzyme supplements to ensure optimal nutritional status. So, this was our short-term plan. How about the long-term? Now, once this patient complete their course of IV antibiotics, they are commonly discharged home with a long-term course of ongoing oral or inhaled antibiotics. Patient also commenced on oral azithromycin. Other anti-inflammatory treatments such as inhaled or oral glucocorticoids may also be used. Additionally, patient with evidence of bronchodilator response in spirometry can benefit from inhaled bronchodilators such as salbutamol. Now, remember that azithromycin is some macrolide antibiotics, and it is used in treating chronic Pseudomonas aeruginosa infection because it has got both two effects. It's antibiotic and also got anti-inflammatory effect, and it can penetrate the Pseudomonas aeruginosa biofilm and can boost the neutrophil function. And the use of long-term azithromycin has shown to decrease the frequency of CF exacerbations and reduces the progressive decline in lung function. So, you know that the progression of pulmonary disease in patient is with cystic fibrosis is related to inflammatory response. So, anti-inflammatory medications are used commonly to reduce this process. So, significant portion of the patients with cystic fibrosis, they are prescribed inhaled glucocorticoids. However, there is no clear evidence regarding their benefit. And the use of oral glucocorticoids is even more controversial because of their systemic effects. When we all know that there are many systemic effects of glucocorticoids, including growth suppression, osteoporosis, cataract, glaucoma, peptic ulcer disease, hyperglycemia. It can cause adrenal suppression and some mood personality changes, to name a few. Okay, so pancreatic, I like to talk a bit about the Dornase alpha, and this is actually a pulmozyme. It's a purified solution of recombinant human DNAs. Patient with cystic fibrosis, they have a high concentration of neutrophil-derived DNA leading to thickened sputum. So this Dornase alpha hydrolyze this DNA to reduce sputum viscosity and help improve the sputum clearance. So additionally, patients with evidence of bronchodilator response in spirometry, they can benefit from inhaled bronchodilators such as salbutamol. So they could benefit from pulmonary rehabilitation. In addition to managing the pulmonary component of cystic fibrosis, patients need to be on pancreatic enzyme supplements for their pancreatic insufficiency, along with insulin and or oral hypoglycemic for their cystic fibrosis associated disease. Okay. So depending on the specific mutation involved in the pathogenesis of cystic fibrosis in patient, drugs targeting the CFTR protein such as ivacaftor may be used. So evacaftor actually is a CFTR potentiator because as it binds to the ion channel to increase its likelihood to be opening and enabling the chloride channels to pass through. It is currently only indicated for patients with a very specific mutations and it's called G55-1D mutations. It is also available as a combination of drug with lumacaftor for patients who got 2 copies of another mutation called F508 deletion, the del mutations. So as the disease progresses, patient can get worsening dyspnea and hypoxemia even at rest. Patient may benefit from home oxygen supplementation and patient may also be considered for lung transplantation. So there is no actually significant evidence regarding the oxygen supplementation in patients with cystic fibrosis. However, patients with end-stage lung disease could benefit from oxygen supplement for comfort. And they are also at high risk for hypercapnic respiratory failure and depending on their blood gas results could benefit with target oxygen saturation of 88 to 92%. Lung transplantation in patient with cystic fibrosis, it usually involves both lungs because leaving a native lung involves there's a high risk of infected secretions affecting the transplant lung. So the workup process and discussions around lung transplantation should occur through the disease process rather than once patient get to end-stage lung disease. Patients with cystic fibrosis who have lung transplants generally have a better prognosis than other indications for transplant and they got a median survival of 9.2 years post-transplant. So that's all about the cystic fibrosis. I hope that it is helpful to you. And as I mentioned, this case can appear in your consultation station as well as in your respiratory station. So just be well prepared for it. Thank you very much and I'll see you in my next presentation.